we are changing our lineup just to keep it fresh, make sure that everybody's still with us, and they realize that Mathilde is not me, and I am not Mathilde. So there we go. We are on to our final session, and we will come back to the issue that we started with in the morning that was discussed at length in the morning about multidimensional crises. So looking at health and well-being and, of course, social protection in the context of multidimensional crises. And we have our final chair for the day is Erika Placella, who is the head of global health at Swiss Development Cooperation Agency. We're delighted to have Erika back with us. Before I hand over to her, just let me give you a very quick run through the session. We will have other speakers. We'll have Nicole Valentin from WHO and Mathilde Melfer from the ILO. We'll also have a very important role in our session, making sure that bringing in our speakers and making sure that everything runs smoothly. And then, of course, we have other speakers who will be joining us remotely and also in presence. So we have Tom Winfield from the Liverpool School of Tropical Medicine, who will be joining us remotely. We have Mike Woodman, Senior Public Health Officer at UNHRC, who will be also joining us remotely, and Lindiwe Mvusi from the National Department of Health in South Africa, who has been with us the whole day and who will finally make her contribution. And then we have two discussants who are here with us, Umberto Cattaneo from the ILO and Sudhir Singh, who you met earlier this morning from WHO. We aim to have some time for questions, so please, if you do think of any questions during the session, if you are online, please do make sure to type your questions in the Q&A chat, and we will make sure to answer them. And if you're in the room, of course, make a note of your questions, and at the end of the session, we'll come to the Q&A segment, and we hope to be able to hear your question and then have that answered live. So, without further ado, I will now hand over to our session chair, Erika. Over to you.
Thank you very much. Can you hear me? I'm not sure. Okay. So thank you for the invitation to be part of this panel. Actually, I spent last week in the Western Balkans in Albania to conduct an internal assessment of the health sector in Albania in order to set Swiss priorities for the coming years. And guess what? What is the main finding? I mean, so it's financial protection. That was the main finding in my report. The thing is that in Albania, public spending on health remains low. It's at 2.9%. So if it's one of the lowest against the target, it was 2.9% in 2020, and against the target of 4.5. That's what is in the health strategy. And of course, it continues to be dominated by hospital spending, which is at 53%. Now, if you think about so this is much higher than the OECD average, which is 40. So hospital spending within as out of pocket. As a result, of course, the health system remains largely in Albania, remains a country on its path to be integrated into EU, just remembering that. So it remains largely dependent on out-of-pocket spending at 59.7 out of pocket. Well, that's huge. Of course, it creates, as you can guess, it creates barriers for citizens to access health, especially for vulnerable groups, which are at-risk women, Roma families. There are a lot of Roma families in Western Balkans, including in Albania, unemployed youth, the elderly, and people with disabilities. Now, As a result of this, Albania's UHC service coverage index, which it measures, the index measures access to essential health services, remains below the WHO European region average of 81 in 2021 and was the lowest of all countries in the WHO European region. That's Albania, a country which is now preparing, which is now negotiating its access to EU. Albania. So what are the causes of that? Because it was part of the assessment just to identify the causes of this situation. So, well, taking a look at the costed health strategy. So there is a health strategy, it is costed. And taking a look at the health strategy and at the same time at the budget of ongoing programs. So there are a lot of vertical programs, for example, cancer screening, NCD screening, oral health screening, and etc. So it shows just taking them just, like having a look at the strategy and at the budget of ongoing programs, one sees that they are not aligned, actually. They are not aligned and they are not in line with what has been approved and costed in the strategy. And to address this critical situation, there is a very recent monitoring report from a civil society organization saying that there is a need to reassess priorities based on sound analysis of demographic, of course, because it has changed, age, health, socioeconomic conditions, and levels of vulnerability, and to mobilize resources to align the budget allocation with the strategy. It doesn't say they need more resources. They say open the box of the mandatory health insurance and have a look about the benefit packages and the way the system functions. So this is exactly what I said. So this discrepancy between what is costed in the strategy and then the budget which is allocated, which is sometimes inversely proportional. And then another problem, as I said, is that there is a mandatory health insurance fund dating back, I think it was 2003. I remember 2003. But the health insurance fund is under the Ministry of Health and Social Protection. It doesn't have any kind of autonomy. So meaning that the marge de manœuvre is very, is very little. And of course, the fund is largely dependent on decisions taken by the Ministry of Health and Social Protection. So the ministry has been merged 10 years ago. It was Ministry of Health. It has been put together to work at this interface, which is actually not the case. So, and there is really a need to update the packages, as I said, of services covered by the insurance, by this fund, and costing new models, because we introduce new intersectoral models which, for example, like home-based care or health-promoting schools or addressing primary and secondary prevention at the primary healthcare level when it comes to NCDs. But those services, they have been costed by the SDC because we never introduce a model without properly costing. So just to give to the government, the entire package, how much would it cost? And sometimes it doesn't cost a lot, but it needs a rationalization, within the funds, within the services, within the packages, which actually is not, they just add layers, new models, but there is no cleanup of, so you know what I mean. So, and that's one of the problems. And then another reason, of course, as I said, is the lack of intersectoral cooperation to institutionally and financially sustain these models. There are a lot of very good intersectoral models which have been introduced by the SDC. We are the only bilateral donor in health. So we really have leverage. There is no fragmentation in the country. There are no other donors like jeopardizing what we are doing. So there is a very good conducive environment to introduce those cross-sectoral, multi-sectoral models. But then they are not financially sustainable. 10 years trying to sustain the home care model. And when we go to the Ministry of Health, it says, But it's not in my, it's not costed. Even if it's costed, we have to do our own costing. It has to be subject to a law. And then the Ministry of Social Protection, which is actually the same ministry, but two entities. No, but it's not, that's health. In school, it's health. But then we say, okay, but in school settings, more about life skills, life skills like, it's not really health. You're not going to send a nurse in schools. It's more about, like sexual and reproductive health and rights, online harassment, this kind of thing. Well, no, but it's still health. So we don't have to pay for that. There is a need to have a nurse because you have a lot of suicides, online harassment. So and nobody really feels responsible for, finance, for sustaining those models. So the models are there, the needs are there. It's clearly showed that there is a need to move away from large psychiatric hospitals, for example, and to introduce the community-based mental health centers or the youth-friendly centers, But again, it's a new model. So if you have to make it financially sustainable, you have to open the insurance scheme and have a look at hemodialysis for 50 people. Maybe it's not really, So there is a need to rationalize. And so what can we do? What can the SDC, state agency, what can international cooperation do to address that in a system, in a country where there are not too many, interferences from the government, but also from the donor community? Because as you know, health is not a priority for accessing, EU. There is this acquis communautaire chapter 28, but it's more about food safety, falsification of drugs, but it doesn't say strengthen your health system. But it says social protection. But social protection in the sense of, ring fencing, how should I say this? Avoiding having too much criminal, activities, being sure people who are dangerous stay in sheltered institutions. You see what I mean? It's not that kind of social protection we are referring to here. So again, there is no carrot from EU on social protection and health and social protection, health, and the social sector, social services to be, integrated, costed, and covered by the insurance, of course. So what can we do? So first of all, we continue to advocate for overall health system agenda, because without regionalization, without hospital master plan implementation, without decentralization, health financing autonomy, you're never going to make more resources available. So there is a need still to have to move forward with the reform agenda. So it's a political issue. First of all, 1, 2, promote a systemic approach to health systems, strengthening since the fall of the communism in Eastern Europe. So Switzerland has supported reform-oriented efforts, working at all levels in Albania, not only in Albania. It goes from health promotion in community settings to NCD's management as health facilities level. It is important, as I say, to cost all interventions, especially when introducing new models. We have to know how much it costs to cover those costs. And because one day, international cooperation has to step out of this and to hand over to local and national authorities. Then the most important thing, so reform, health system strengthening, it's to be sure that to have at the core of this health system strengthening approach, that we support health financing. We support the reform of the entire health financing system. Because the only thing I will recommend in my report is to offer to the mandatory health insurance fund to open the scheme, to have a look at the scheme. We did it in Moldova, for example, to have a look, to rationalize and to see where there is room for covering the newly introduced services. So that's very important. And this has to be done, in the case of SDC, it has to be done at the highest level at the embassy and put as a condition, okay, if you agree to open the mandatory health insurance scheme, we will support you. But outside of that, sorry, these are structural issues. We cannot do more than that. We cannot continue to financially make those models like financial viable. And then, of course, promote multi-sectoral cooperation, as I said, so between the Ministry of Health, the Ministry of Education, in the case of health, promoting school, and etc. And the advocacy with civil society organizations to hold the government accountable for effective and efficient delivery of inclusive services which are integrated. And then you have, of course, you have parents on board, you have, schools, teachers, and etc. So it's very important to have also them on board to promote this intersectorality. And of course, these interventions have to be combined to have the greatest impact. And they need to be, of course, accompanied by not just policy, but political advocacy, which is different. So we are not there just to, we have policies. There are a lot of policies on integrated care. But what is missing is really this political dialogue with both ministries and with the Prime Minister. And so that's my specific case. It's very fresh. It's from last week, but you see it was very much about health financing and social health protection and universal social protection. So super. It's you now. Well, thank you. So I'm handing over to for the next block, which will allow us to go deeper inside into cross-sectoral work. Thanks.
Thank you. Okay, we're going to turn. Thank you so much, Erika, for that fiery start to the session. We didn't expect anything less. From Tirana. So that is great. Getting us started in a very passionate way, and we shall continue in a very passionate way. So let me introduce our next speakers who will also help moderate the session and be the red thread through the presentations that will follow. So we have Nicole Valentin, who is the Senior Technical Officer for Social Determinants of Health, Equity and Health at the WHO. And of course, our very own Mathilde Melfer, Health Financing and Social Health Protection Officer, Technical Officer at the Universal Social Protection Department. So I will be sharing my screen. For, yes, Tom, I think you're sharing your screen, but we're not quite there yet. So, so thank you. I'm very glad to see that it works, but I will start sharing our screen. Okay, so let me get the presentation started. It just takes a while. There we go. Over to Nicole and Mathilde.
Thank you very much. Thank you, Costanza. And thank you very much, Erika, for this great kickoff. I think it's really showing, the concrete challenges that you are trying to address today. And we hope this session will really bring some of these, concrete steps that we can take forward to really take action into what we have learned and heard about today, discussed. So Nicole and I will provide a quick framing kind of to explain, the train of thought that we had when we constructed this session. So basically, we really wanted to address, the context of multidimensional crisis. I think it's really something that we know every day in our daily life, in the media, everywhere. And it has a profound impact on our lives. And universal social protection can be really seen as a tool to address those different crises. So if you can just, okay. So that's a triad representing what could be a multidimensional crisis. I think what we can see here quickly is that we can have 4 different dimensions by which crises happen. Economic, social, political, environmental. and all their origins as well as consequences are interlinked. They're feeding on each other. If you look at the financial crisis 2007-8, or obviously more recently the COVID-19 pandemic, it has, impacts on all the spheres of the societies. It has impacts, of course, on the economy, at the social level. We have heard this morning about the impacts of the public health and social measures on different social exclusion, poverty, etc. So this complexity, really, and interlinkages are really calling for an adequate response, but also complexifies, right, the kind of response we could give to those different crises. So if you can just go to the next slide, please. When we are considering those different spillover effects, we should really see that actually universal social protection as a determinant of health, as well as an adaptation and mitigation strategy, can really address those different aspects, those multidimensional crises. So when we talk about universal social protection, of course, we talk about a very comprehensive response. So, of course, income security along the life cycle, as well as access to affordable healthcare, and social protection has far-reaching implications. I think we understood that today, but it's worth reiterating that really it's not only, and it has an important impact for health and well-being, but also it has an adaptative impact. If you think about, for example, this protective effect for everyone, including the most vulnerable, and helps coping with different consequences of those crises. And I think in fine, it really has a mitigating effect on crisis, and even a strengthening systems effect. So, for example, if you think about the causal relationship between formalization and taxation, social contributions raising, and then, of course, increasing the fiscal space available for social sectors, or even the political dividends of such policies, it really has this strengthening systems effect. So now, if you can move to the next slide. This complexity also reflects, of course, at the level of determinants of health. If you take, for example, here an NCD, so cardiovascular diseases, for example, we can see that, of course, policies, cultures, and values, the economy, they act as psychological stressors that are risk factors. Food insecurity, lack of access to healthy diet, etc. They are, all causes of such disease, and of course, social and care services access also have a role to play, a very important role to play. So if we look at all those dimensions, those are very complex problems to address, right? If we want to improve population health in this regard, and social protection is part of it, but alongside other sectors, and this is where the intersectoral action really should come in.
And so as we build from multidimensional crises to multiple determinants, as we saw for cardiovascular disease, we land upon multisectoral action. And next slide, please. So the health sector working alone cannot address the determinants of health, that's for sure. And Erica's example was brilliant in illustrating a lot of the challenges we face to have more integrated systems that adopt a very broad approach to care in society. Next slide, please. This means public health actors need to work together hard for agreements and on the relationships with other sectors. And we have lots of examples of these in quite siloed manners. And what we're hoping the framing of this session will outline is the start of some building blocks to have a more systemic approach to our collaboration between the health, labor, and social protection, social development areas. Next slide, please. We want to produce a virtuous cycle. We want to go from the vicious cycle to the virtual cycle. Click again, please.
and again. So which is inclusive development, then fostering healthier populations with equity and fostering, again, inclusive development. So multi-sectoral work is needed to bring about this virtuous cycle. Next slide, please. And this means each of us in this room need to be boundary spanners. It's not only about my space of work, and I mean this also within each of our sectors or their space of work, but it's about looking at the boundaries, looking at the cohesiveness, opening up the black box of the social security, financing, etc. Next slide, please. And building those bridges that are needed to bring about, say, the costing of new models, to bring about sometimes there can be savings or rationalization. That is true. But at the same time, we do want to make sure that a consolidated financing for social development and the social sector doesn't necessarily mean reduced funding because we're an easy target. So we need to advocate together in an intelligent way. Next slide, please. And so we build on a lot of what we know in public administration, at least from the health sector. We call these skills the health and all policy skills, but they're really about supporting whole of government holistic approaches to social development. And on the left here, you see one of the models that we use for building capacities amongst the health sector. And today, what we're hoping to take forward is some framing in the presentations that are coming up around information and knowledge and evidence, how building the evidence together is important for looking at mutual benefits, how advocating and negotiating with internal and external actors is important to do collaboratively, how looking at coordination and integration of services is also important to work out collaboratively. And lastly, we're going to be looking with Umberto at opening up the financing a little bit on making the case in terms of financing gap and how these tools can be used collaboratively as well. So, and that's really the broad framing I wanted to do. Our last discussant is Sudhir, who's not up here yet, but he'll be coming soon. And he's going to just talk then about how in our work at WHO for working on advocating for the social determinants of health equity, it's so fundamental for us to have collaboration because we can't finish the work for health equity by focusing only on health and medical care. Well, let me say medical care services alone. So thanks very much. And that's the framing for today. And we thank you for helping us to think through these issues together, as well as for the previous sections of today, where those sessions also will provide important key messages and building blocks regarding this collaborative relationship that we are building. Thank you. Now I think I'm going to introduce the first speaker. Is that right? Yeah. Okay, so let me just go back to my notes. My first speaker is Tom Wingfield, who's a reader in tuberculosis and social medicine at the Liverpool School of Tropical Medicine. On track? Yes. He will reflect on this first building block idea we have, which is overcoming the silos to generate evidence, bridging research gaps between health and social protection, the case of the Sparks Network. Tom Wingfield, over to you.
Hello, everyone. Can you hear me okay?
Yes, we can, Tom. Maybe just slightly raise your volume if you can, just for the sake of our interpreters.
Sure. Thank you. Thank you for this opportunity. My name is Tom. I'm a reader at the Liverpool School of Tropical Medicine and the Deputy Director of our Centre for TB Research here. Thank you for the opportunity to talk about our Sparks network. So what is Sparks? So Sparks is the Health and Social Protection Action Research and Knowledge Sharing Network. So a bit of a mouthful, but it was set up over a decade ago by people that I can see online, including Delia Butcher of the London School then and now WHO, and Knut Lomroth, who was of the WHO and now Karolinska Institute. And it was and is a group of people from different disciplines, so epidemiologists, clinicians, implementation scientists, policy and decision makers, advocates, and TB civil society representatives who came together really with the focus of working on social protection initially in the field of tuberculosis. And we've expanded to have members from countries around the world, over 25 countries and 162 members at the latest count. And the network is headed by this wonderful secretariat. So Wanga Zembe Mkabile from South Africa, Rachel Force, who's working in Vietnam, and Liva Van Leeuw, who is working in Finland and also South Africa. And finally, who I also see online, Mauro Sanchez in Brazil. And the overarching aim of our network is to optimize the design and crucially co-design with people who are affected, delivery, evaluation, and policy translation of research in the field of social protection. And we divided ourselves up thinking of the question about how do you kind of interact with these different areas and different sectors into different working groups to try and cover as many areas as we could most efficiently. And those were systematic reviews and meta-analyses. What was the evidence that was out there and existing in the scientific literature about social protection? We did mapping of social protection programs, so not just the scientific literature, but what's actually happening on the ground in terms of national or subnational level programs, policy and practice. And then I'll talk a bit later about the intervention studies and the cost surveys that we did. So primary data and research that was led and delivered by our network. I think it's worth noting again that most of the working group initially over the first few years was very TB focused, with TB being a real indicator as the archetypal disease of poverty and something that could then be applied to other disease processes. And through all of these working groups, we tried to align what we were doing in terms of research and policy questions, so potentially informing some of the PICO questions of guideline development groups, including through WHO, and also importantly to align our methods and our outcome measures so that we could potentially pool our results when we needed to try and add to the strength of evidence. And more recently, we've come to applied learning and research going beyond tuberculosis. So not just in terms of beyond TB as a disease to other illnesses, such as non-communicable diseases and maternal care, but also to other areas such as cash transfer plus interventions. So not only things like social protection, but also how do we combine that with other needed interventions such as psychological support. We've contributed to a number of policy documents, and I see Ernesto Jaramillo as one of the members in the audience who's been crucial in many of these policy documents. So TB patient cost survey, framework for collaborative action on TB and comorbidities, and the results from the national surveys of costs faced by TB patients and their households. Most recently, again, led by Ernesto, we've contributed to the guidance on social protection for people affected by tuberculosis. And that was linked in with the UN high-level meeting on tuberculosis, which came up for the first time with the goal of, by 2027, a pledge that 100% of people with tuberculosis would receive a social benefits package. And as a network, we've been able to advocate for that and kind of raise that up the agenda in the scientific literature with comment and interpretation of some of these guidance, such as here in Lancet Public Health and also in the International Journal of TB and Lung Disease, to try and really get the message across to both researchers and also to the wider public and partners. In terms of systematic reviews, I know Prof. Salah Atkins was talking earlier today and a related meeting on Monday. And this is some work that we've done on conditional and unconditional cash transfers. What's the evidence on what people think of these cash transfers, those people who receive them? And more recently, as we're still doing lots of work in this area, and this is a systematic review and meta-analyses using the World Bank definition of social protection to try and look at how that impacts upon TB treatment success, so becoming cured. And that work that's under review currently shows that there's a twofold likelihood increase of TB treatment success in people with TB who receive social protection. We haven't got much time, so just in the last couple of slides, just to give you an update of the actual primary research we're doing.
Yeah. If you can wrap up, thank you very much.
Yeah, we're in Nepal and Indonesia. We're doing implementation trials. Same in Vietnam with cash transfers and health insurance. In Mozambique, mixed method studies on long-term outcomes of TB. In Uganda, exact TB trial and implementation science on the care cascade. South Africa, mixed methods research on social protection for children, carers, and disabled people. And Brazil, ecological studies on existing social protection programs. So in conclusion, we're an inclusive interdisciplinary network working across sectors to advance social protection. We work in collaboration with multi-sectoral partners to address no-do gaps in this field. And we are expanding beyond TB to other illnesses and to also consider universal social protection and health coverage. And we have a broad range of experience and expertise, and we do welcome new members and partnerships. Thank you for this opportunity.
Thank you, Tom. So Tom's description of his work just illustrates how important it is to bring together the social protection impacts and health impacts. And we've built on in our work for COVID, which was presented at the beginning of the day, we really leveraged that work a lot. So thank you very much. Now we're moving on to a second panelist who's going to be looking more at advocacy issues in terms of how it's impossible in certain refugee settings to separate out the social protection needs and the healthcare needs and how these work together and are mutually synergistic. So with great pleasure, I'm going to hand over to Mike Woodman to introduce himself and then to lead us through this new presentation. Thank you, Mike.
Thanks, Nicole. Nice to see you and all the other colleagues there. Can you see my presentation?
Yes, it's good.
Good. So I'm just going to talk about the challenge of protecting forcibly displaced people. Refugees are often the most vulnerable within societies, and to talk about the example of Kenya. So in Kenya, there are over 800,000 refugees, protracted crises in neighboring countries, 400,000 in the east, the Dadaab complex of camps, nearly 300,000 in the northwest, and then just over 100,000 urban refugees, mainly in Nairobi. Now, I'm going to focus on the urban refugees because this is where we've achieved the most in social health protection. Refugees have been able to access healthcare through the national system on par with nationals since 2008. Before that, there were parallel services through NGOs. With the rollout of national health insurance in 2015, through very strong advocacy, it was agreed to include refugees in the rollout, which was a great success, through joint advocacy, not only UNHCR, but WHO, ILO, and others with a stake in UHC. So today, there's approximately a quarter of urban refugees are enrolled in NHIF subsidized by UNHCR, and I'll come back to that later. This is the big issue, and Erica mentioned it earlier, is sustainability. So we currently support the most vulnerable refugees, but this is only around a quarter of the population. But then there's really three categories. There's from the most vulnerable to the moderately vulnerable, where there's a transitioning model where we can work on a co-payment basis, UNHCR contributing and refugees contributing, and finally, the group that are fully self-reliant. Obviously, the objective would be that most people are self-reliant and can contribute to their own premiums, but we need to recognize there will always in any society be those who need a safety net. Now, as I mentioned, the challenges with financing. So we currently finance the most vulnerable through support through our donors, but there's insufficient domestic financing to take this on. Understandably, Kenya is trying to roll out for the whole country, and often countries are a bit reticent to include refugees in their domestic financing and budgets. And this is where we need to come together as partners on advocacy, but also supporting financing through a transitional period. Just to mention the camps, Dadaab is a very complex area, but in the northwest, Kalobey, there's a much more open camp integration with host communities, access to livelihoods. And here we have done inclusion of refugees in the National Health Insurance Fund, also progressing over handing over health facilities to the Ministry of Health. And this appears to be successful and is a model that can be expanded next year. So just to wrap up, really, the key messages are that, taking the Kenya example, refugees face significant barriers to access healthcare, but Kenya's policies and inclusiveness of refugees really offer hope. However, expansion is needed. Political commitment is critical, as we've heard before, and I think here is where we can come together as partners to jointly advocate, all of us with a stake to supporting member states to achieve UHC, whether it's WHO, ILO, ourselves for refugees, bilateral donors, development partners, etc. We need to come together to keep that momentum. And as mentioned, health and social health protection need to work together. Often entry into the health system is a springboard, as we've seen in Kenya, to then move towards social health protection. Critically, self-sufficiency, self-reliance is key when we talk about refugees, but this means favorable policy environment where people can access the labor market, can also access education and skills training. As I've mentioned, financing is really the critical issue, not just in Kenya, but across the board with refugees. Apart from high-income countries where domestic budgets cover refugees, we need to support countries recognizing that there needs to be a transition period, and partnerships can also help resource mobilization. Just finally, including refugees in social health protection is essential to achieve UHC, and we need to make sure that no one is left behind. Thank you.
Thank you very much, Mr. Woodman. That was very interesting. We came from the generation of evidence with the Sparks network, and now really, we understand from your presentation also the importance of joint advocacy, the importance of intersectoral work already. You mentioned, the importance to have different set of policies, education, healthcare access, job skills. So all those different components are definitely of great importance when we are working at the intersection between the USP and UHC. And so with that, thank you again for your presentation. Now we will move to different topic, but in the continuity of your presentation, now we want to address the case of TB again. So TB is really a disease that shows specific characteristic. When you think about the fact that it has intertwined roots in poverty, in social exclusion. It can also, because of tuberculosis, conduct to different vulnerabilities for which social protection is needed, access to social health care is needed. And it's therefore a good example somehow that, both the social protection and the health sectors need to join forces. And in that case, I wanted to mention the different efforts that have been implemented by the international community to address TB. If we think about the WHO's end of TB strategy and TB strategy, where you have social protection as one of the key components, and now more recently the multi-sectoral accountability framework for tuberculosis that really puts the emphasis on working beyond the health sector, really, and work hand in hand with social protection and education sectors, for example. If you are also interested, Tom already mentioned in his presentation the joint WHO and ILO guidance on social protection for people affected by tuberculosis. And this is really showing this publication, all the tools that are available also for the TB community to be able to also have a voice in the social protection dialogue and really have their social protection coverage also extended really to this population group. So I would like to then introduce, to move on to our third building block, the third panelist, Lindiwe Mvusi. Thank you for being here with us. You are Director of TB Control and Management at the National Department of Health of South Africa, and you will speak to this third building block, which is the institutional collaboration mechanisms for integrated delivery, the case of TB in South Africa. So thank you for being with us. Yes, okay. And now you have the floor, Dewi. Thank you.
Thank you. I'll go straight to the point due to time. Yes, TB is, in our setting, is mainly driven by HIV and poverty. And what we've seen in earlier studies was that providing incentives to patients in terms of cash or food incentives, it improves outcomes. We had focused mainly on that previously, but then in our National Patient Cost Survey that we conducted in 2020, we also found that about 56% of TB patients face catastrophic costs. And in addition to that, people are driven more into poverty by just having an episode of TB. And if they are employed, whether informal or formal sector, they face job losses or loss of income as a result of seeking care as well as staying on treatment. And again, in recent studies, we have seen that addressing poor nutrition not only reduces the risk of TB, of people developing TB, but also leads to better treatment outcomes. Now, to address these challenges, we then had to cut the cycle of TB and poverty, we have had to engage other sectors and stakeholders to address the social determinants. Some of the government departments mainly that we have been engaging with would be social development, because they are mandated to provide social protection services to all people in need. And then the Department of Employment and Labor, which is responsible for labor and industrial relations, job creation, unemployment insurance, as well as they are the custodians of the Occupational Health and Safety Act. So in our engagement, mainly it would be focusing on ensuring that people are accommodated within the workplace during the treatment period, and also ensuring that there's access to unemployment benefits for those who have some temporary impairment. And lastly, to include compensation for people who have occupational TB and are eligible for that. And within that, there's also the Compensation for Occupational and Diseases and Injuries Act, which is administered by the very same department. But this excludes minors, so minors are dealt with under a separate act, which falls under health. Now, other government departments as well that we have engaged include education, the correctional facilities or services, infrastructure, agriculture, and mineral resources. But then in addition, we've also had to engage employers and labor representatives so that there are also workplace policies that address TB to address the problem holistically. Now, how we coordinate this, we have at cabinet level, TB caucus, which is mainly to ensure that parliamentarians lead the response to TB in the country. And then at government level, we have what we call a social protection, community and human development cluster, which is 16 government departments and which address cross-cutting programs. And the main aim of this structure is mainly to improve planning, joint planning, decision-making, and service delivery. And then we also have a multi-sectoral platform, which is mainly the South African National AIDS Council, which is under the Deputy Presidency's office, and it is represented by a number of sectors, which include government, business, as well as the civil society. And then this is mainly a structure that we use effectively because A minister in one government cannot call other ministers, and this is the main forum that we use to actually then coordinate our activities. Within that structure, we also have the TB multisectoral accountability framework, which is aimed at strengthening accountability by all the sectors. So they are expected to have their plans and account in terms of progress. The same structure is replicated at a subnational level to ensure that what we are doing nationally is done at provincial level. We do have challenges. And what we're picking up is that awareness on rights and services that are available and how and where to access these services is weak at community level, so people don't know what is available and where to go. And then again, the other challenge is obtaining buy-in from the different sectors. It's a long and lengthy process to get people to understand where the vision, basically. And then the M&E systems currently to monitor what is happening are not available. So it's difficult to actually report on the response broadly. And I think what is currently the main challenge is that there's fragmentation of services, health, social development. The different government departments don't really come together in terms of planning now on programmatic issues. So in conclusion, really, much as we have the legislation, regulation, policies, as well as the governance structures in place, this has not really translated into improved access and integration of services at community level. And I think that should be our next step in terms of trying to actually strengthen this collaboration. Thank you.
Thank you so much, Mrs. MV. That's really, really interesting, and really speaks also to, it echoes a little bit to the sessions we had this morning about the need also for OSH, social protection and health, to come together. All sectors need to have a dialogue across the board. The need to really have a political commitment, as well as relevant accountability frameworks at all levels, and M&E tools. So while also understanding that there are still big challenges in terms of a fragmentation of services, which are also a big piece to tackle. So thank you again. Now I would like to kick off the discussion with the two discussants we have today. And it is my pleasure to introduce my colleague Umberto Cataneo, who's a public finance economist in the Universal Social Protection Department of the ILO. He will allude to the challenges that are related to financing and resource mobilization, specifically when it comes to joining forces and the need to really find ways to finance USP, also coming from different angles. So thank you so much, Umberto. The floor is yours.
Thank you very much, Mathilde. It's my pleasure today to be here. And I would like to start by saying that the ILO has produced a large body of evidence showing that investments in universal social protection and universal health coverage builds human capabilities, but not only, they improve productivity, they improve the formalization of workers, and at the same time, they reduce poverty and inequalities. For example, a recent study we have published just last month showed that countries with larger health coverage are also those with lower income inequalities. And when it comes to social protection cash benefits, old age pensions are the most powerful cash benefit to reduce income inequality, due also to their capacity to ensure healthy aging to a growing share of population in old age. Well, given these benefits, despite these benefits, and the well-documented evidence regarding additional benefits that I have not mentioned, countries in the past decades have been held back from making the necessary investments. Why? Well, this is due to an agenda of deregulation, financialization, endless austerities that have scaled up inequalities, and also in a context of global rising temperature and climate shocks. Today, we are more than a decade since the adoption of the landmark ILO recommendation on social protection floors, number 202. And we are also 5 years left to the end of the 2030 agenda. Despite this, close to half of the world population, or 3.8 billion people, do not have access to social protection, let alone the adequacy of this benefit, because even those that are covered, they might not have access to adequate benefit. If we do a rapid calculation at the global level, we see that it will take 49 years at the current pace to achieve universal social protection. It will be in 2073. But the question now is, how much does it cost to ensure universalization, if we want to have universalization today? Well, we have launched the ILO financing gap calculation in April 2024 at the Financing for Development Forum in New York, and we have done that together. So we have done social protection cash benefits and essential healthcare. Why? Well, we have heard it today. Social protection and healthcare are interrelated. We have heard it in the presentation of Matilde and Nicole, but we have also heard from Tom that social protection double the livelihoods of those who are treated by TB treatment. But also with Erika, we have heard that in Albania, the Ministry of Health and Social Protection are joined. So it was very important to have this estimation done jointly, to have that they are basically a powerful tool for intersectoral advocacy within governments. So without further ado, I would like to give you these numbers. So, and some of you might already have heard these numbers that are published in the World Social Protection Report. So in low and middle income countries, the financing gap to achieve universal social protection is estimated at 3.3% of the GDP of these countries on average. This corresponds to 1.4 trillion per year. Of these 3.3% of GDP, 2% of GDP are required for essential health care and 1.3% for the 5 key social protection cash benefits. What to do to mobilize progressively the resources to close this large financing gap? Well, we think that countries need to set realistic short-term targets, and this will move the needle. Last week, we were in New York at the second preparatory committee of the 4th International Conference on Financing for Development, and the ILO, together with the USP 2030, the Global Partnership for Universal Social Protection, issued a call to action for countries to prioritize public investment to extend social protection coverage by at least 2 percentage points per year. What does it mean? For a country that has 50% coverage this year, it means to aim to reach 52% coverage next year. And this is actually is our call to action. And the ILO database, the ILO World Social Protection Database, show that this minimum target, which is really a minimum target, is both feasible and achievable based on trends that we have observed over the past decades in 35 out of 135 low and middle income countries. So this is actually achievable. But how to find the necessary fiscal space to achieve and to comply with this call to action? We need bold solution, and governments need to prioritize domestic financing through progressive taxation on income and poverty, carbon taxes, as well as social security contributions. It is also important to address tax evasion and illicit financial flows. International financing mechanisms are also critical to enable domestic resource mobilization, especially when it comes to address debt distress, which is a major source of crowding out of the fiscal space for health and social protection, and we have heard it today. In conclusion, it is important to promote the extension of social protection floor and system, taking into account the national circumstances and challenges of creating fiscal space in the country. And we think that the call to action is a concrete step to move in this direction. Thanks.
Now we're talking my language. Thank you so much. That's so inspiring. And now, as we move from mobilization of resources, we're going to look at reaching our ultimate objective, which is really equity and social justice. And for that, closing comments from our second and last discussant, I'm introducing Sudhvir Singh, who's the head of the unit Equity and Health in the Department of Social Determinants of Health at WHO here in Geneva. Thank you, Sudhvir.
Thank you so much, Nicole, and thank you, colleagues, for being here. Thank you, ILO, for hosting us. Wow, what a rich discussion. Started very dauntingly with these multidimensional crises, the excellent example that Erika provided. But then I think we've heard a lot of very practical areas with evidence that are opportunities for us to pursue as well, and then a great investment case that was just outlined as well. And I think this builds on the really progressive dialogue we've had all day. First, looking back at the COVID-19 pandemic and all of the lessons we need to take from that in terms of the role that social protection plays there. We learned about occupational health, we learned about informal work, and now the more integrated session here. I think I'll be brief because I had the pleasure of speaking this morning, and I really wish we can have some interaction before we close. But in terms of the World Report that WHO will be producing early next year, we start this report by really giving a status update of where the world sits when it comes to health equity. And the last global report from WHO, the Commission on the Social Determinants of Health in 2008, they set some pretty bold targets for how we can measure whether we are making a difference. And we give an update on that, and it's a bit of a mixed picture. On the one hand, there has been some progress. We should recognize that in areas like, for example, child mortality, we've seen a halving of child mortality in the last 20 years, a lot more to do. Between countries, in terms of the life expectancy gap, we are seeing a gradual convergence, which is welcome. Of course, we want to see that accelerated. But there's also some deeply worrying signs. For example, within countries where we have data, and there's a huge absence of data, but within countries, when we compare social groups and when we disaggregate, alarmingly, it looks like the gaps are actually widening in many countries. So then we look at, why could this be? What does the evidence tell us? And essentially, there's been a lack of action on the root causes of these health inequities. And that's what we've been talking about today. We've been talking about economic insecurity. We've been talking about structural discrimination. We've been talking about an absence of social infrastructure, including social protection coverage. We've been talking about the threats that climate change and conflict are posing to the world. And so we have to wrestle with these very daunting structural challenges. But at the same time, there are practical things that we can do. And we've just been hearing a lot about them in this session here. So we have compiled a series of country case studies. We've compiled a series of evidence-based recommendations. And I think we can learn a lot from each other and from some of the success stories that we have. In particular, we have a lot of lessons from what we call the Special Initiative for Action on the Social Determinants of Health. And we're very pleased to be working in partnership with Erica and the Swiss Development Agency there. We heard a bit about that this morning from our colleague Ariel. And so there's just a lot of lessons and exchange that we can encourage. And so to conclude, I think this World Report will represent from WHO a renewed commitment to this agenda, but also an invitation to partner, because we know that we cannot do this by ourselves, because it goes well beyond the day that we're celebrating today, Universal Health Coverage Day. It really goes beyond that and covers so many areas in our society and so many areas where our colleagues and our partner agencies, such as the ILO, lead on. So we really look forward to doing much more of this intersectoral work, to partnering and to providing whatever support that we can provide, and for that to really cascade down within countries, within communities, that the health sector can broaden its horizons, identify opportunities to partner, and then work together towards common goals such as health equity. Thanks so much.
Thank you so much, Sylvia. Thank you for our two discussants for their insightful thoughts, as well as for our panelists. So now we have a couple of minutes for questions from the floor. I think, unfortunately, because we are a bit, we have to hurry a little bit. So maybe we'll just take one question. If there is a question in the room, apologies that we cannot accommodate for more. But if there is a question, yeah, we can take over there. Okay. Two questions. Okay, let's go.
My question is for Mr. Woodman about the refugees. And because in the last slide from the key elements, you mentioned how refugees face barriers to health care. And my question was, what is the objective aimed to achieve as an alternative so that all refugees have access to social and health care? Thank you.
Thank you. Yeah, I will come in. Thanks for the question. I think it's a good question. It's a difficult one. The barriers are multiple. So one can be the political, and that's often is just simply not open to refugees because they are perceived as foreigners and not the responsibility of the state. But there's other issues related to language, to culture, to distance. Refugees may find themselves in remote, hard to reach areas. So we need to address all of those barriers and systematically. So it may be the political advocacy, it may be making sure that physical access is there, and it may be making sure that there is cultural interpretation or that health workers are trained. And refugees may have also specific needs. Remember, if they've recently arrived, there may be mental health needs, as well as very high incidence of sexual and gender-based violence. So there may also need to be specific services supported. But I think really the essence is advocating for inclusion in all systems. By and large, we find that most countries are open to let refugees use services. The problem is the financing, and this is coming up repeatedly, that as soon as it comes to domestic resources being used to pay for foreigners or for refugees, this is a critical issue, and this is where we need to really accelerate working with all partners to support these states, but it needs to be sustainable. It's not a question of year on and year on. You'd like to see a pathway whereby refugees are contributing to the society, are paying into social protection, and are seen as a benefit, and therefore absorbed in the whole domestic financing and budget. Thank you.
Thank you very much. Now, in the interests of time, I think we've had a very rich session, but I'm going to hand over to the closing part of the session. First, I'm going to ask Erica to do the closing. Is that okay, Shara? Okay. And then, because we have then some final formal guests who are coming to close sharply at 5 p.m. the whole workshop. Thank you.
Thank you very much. It has been very rich, and I just have a couple of reflections I would like to share with you, and still going back to my Albania example. I think we have, since we started this conversation, trying to bring together, agencies and fostering joint narratives and conversations and, framing. I think we have achieved a lot. I feel more maturity than, even more maturity than we had. And of course, it helped me all this narrative in mind and these examples. I was feeling very comfortable in Albania to speak about what is the interest of having all sectors, in a joint advocacy and work, So that's the first thing, maturity in terms of joint narrative, conversation, framing, etc. That's what you did. And then, so that's my first point. Then the second point is about the importance of research and policy and evidence, to feed advocacy work. And again, brings me back to Albania. Our project, they produced a lot of evidence. There is a lot of research action within the project. Without that, without this evidence, it's not possible to go to the Ministry of Health and Social Protection to say, look, you have to invest because the return are so high and the costs are so high. So there is an interest. There is a case for investment from your side. So, and then of course the political commitment which was mentioned for the refugees. There are a lot in Albania, in the north of the countries. There are a lot of refugees, there are a lot of floods. So every single year there are earthquakes, floods. So there are a lot of IDPs internally, And again, this conversation and this need to integrate them and to cover them with these integrated models is also very important. Joint advocacy work for social sector research, mobilization, etc. This is exactly what I was referring to with this financial and institutional viability. And then you brought a lot of figures, and I give you a figure from Albania. You tell me whether this is attractive or not. It costs 0.5 euro per person to cover home-based care in Albania, in all regions of Albania. So if that is not convincing, I mean, I don't know what return on investment can look like, you know. And my last point is on equity. Of course, we do this for equity. I mean, we don't do it. I mean, and it's not only a moral posture. It's also an economic imperative, because the cost of not being, I mean, of not being fair and not being equitable, I mean, not having an equitable access to services, including in Albania, are huge. And we use it, of course, we use this data, I mean, on inequities, I mean, to feed our policy dialogue, to have it integrated and to have it as part of the mandatory health insurance fund. So that's all from my side. It's very much, you know, I bring a lot of tools to be integrated in my report. So from Albania, thank you. Thank you all. I'm sorry for the questions. We didn't have time, but...
Thank you to all the speakers. Thank you to the listeners. Thank you to people in the room, online. Handing over to Costanza for final closing. Over to you.
Well, echoing Nicole, so thank you to our final panel of speakers. We are now going to get ready for our closing remarks. And if I can, yes, thank you. And I will take my